Hi, everybody. My name is Natalie Yeadon. I'm the CEO and co-founder with Impetus Digital. At Impetus Digital, we have built some of the best-in-class asynchronous and synchronous virtual collaboration and communication tools. We have worked with life science companies from across the globe over the past 13 years to help them with everything from virtual advisory boards, digital investigator meetings, online medical education. And since the launch of our award-winning Insight Events platform, we've been also helping pharma companies with large-scale innovation sessions, MSL training, and large corporate events. But more importantly, at Impetus, we really believe that everything starts with a conversation. And from these big, hairy, audacious conversations with some of the leading edge thinkers, the digital provocateurs, and the healthcare thought leaders, we can all work together to collectively and positively disrupt healthcare. So I'm super excited to having one of these healthcare thought leaders at the virtual table with me today. This is actually Michael Duke. He's actually the principal healthcare consultant with a company called Tilly Baker US. He's also the author of the infamous book, The McPherson Principle, an innovative approach to hitting the bullseye of revenue cycle performance. He has over 30 years of diverse experience and a record of amazing accomplishment in leading people, programs, improving operational outcomes, and developing best management practices within the healthcare industry. He has led several successful engagements that demonstrated an ability to develop and execute executive level strategies. He has proven expertise in the areas of operations management, corporate performance management, and revenue cycle management. Michael actually, in his current role, was previously employed by an international accounting and consulting firm and had national responsibility for delivering revenue cycle improvement results, as well as the design and implementation of proven data analytic solutions for provider clients. Welcome, Michael. So happy to have you at the table today.
I'm excited to be here. This is going to be fun.
Absolutely. I think you have a really, really interesting background. I'd love if you could just give it a very high level, share with us your career trajectory and how you landed at where you are today.
Yeah, sure. So it's now 30 years in the making, a little 30 plus, which is why I no longer have hair. But started out, came out of undergrad with a dual degree in business and management information systems, and had a couple options when I graduated, one for a bank and one going to work for a hospital. And, I was talking to my mom and I said, gosh, I'm not sure what to do. They're very similar. And she said, well, wouldn't you feel better if you're at least trying to help take care of patients than you would just be making money for a bank? And so that launched my my healthcare career. And it's all I've ever done. I've been in healthcare for, again, now the 30 plus years, but it started out in IT. I had a heavy IT focus. I was doing system implementation work, system optimization work. And then through the course of that, after a few years, I had an opportunity to take over the whole IT department of a small hospital in North Carolina. So I took on that job, but within about 6 months of taking that, our revenue cycle leader left, and executive team came to me and said, hey, Mike, can you run the revenue cycle area in the interim while we try to find somebody? And I did that for over a year and found that I really enjoyed operations as much as I enjoyed IT. And I thought, gosh, if I could just blend those two things, really understanding the IT component, but then learning and growing and understanding in detail the operational side of rev cycle, that could be a pretty fun career. And so made the switch, went to Deloitte Consulting shortly after that time, and joined their revenue cycle team as an IT enablement resource. And from there, just kept growing in both components. And now I've found myself, after a couple other stops where I wanted to do some things from an innovation standpoint, found myself at Baker Tilly because they gave me the opportunity to take all of that previous knowledge and say, hey, why don't you build an innovative revenue cycle service offering for us to take to market? And that's what I do now.
Awesome. So you are the principal of this consulting practice. Tell us a little bit about what Baker Tilly does specifically and how they're helping clients.
And we're now one of the top 10 professional service firms. So we're fairly large. inside of healthcare consulting, we have your traditional tax and audit healthcare services. I'm in charge of the healthcare provider segment of our healthcare consulting. We also have life sciences and payer offerings with other leadership. But for me particularly, we have three primary offerings. We're working on a fourth, but we do a lot of managed care work. So we will help organizations renegotiate their contracts, support that whole process, contract modeling and those type of things, reimbursement perspective. Then we have general analytics for healthcare providers. So I lead the effort on designing and delivering meaningful analytic solutions for our clients. And then again, as I mentioned, revenue cycle is probably 50+% of our services, where we go in and do large transformational work where we redesign the entire operations from a process perspective. We redeploy staff in more meaningful areas. We retrain those staff, and then we lock in and really drive significant financial performance improvement off of those. So that's the three primary services that I'm responsible for. But Baker Tilly has much broader reach than just the things that I do, for sure.
Absolutely. Now, you have also recently wrote a fascinating book called The McPherson Principle, an innovative approach to hitting the bullseye of revenue cycle performance. First of all, who is McPherson and what is the McPherson Principle?
So it is named after one of the partners I had at Deloitte, who was one of my mentors. Absolutely brilliant man, Wayne McPherson. And essentially, most of what I know today is a direct result of either what Wayne taught me or the push he put me in from some of the innovative side. But I wanted to name that after him as kind of a nod to all of the things that he helped me with in my career. But the construct behind it was, Wayne had a strong push for we can improve everything every day, even if it's just a little bit. And that's kind of the overall concept of the McPherson Principle is everything can be improved, even if it's 1% a day kind of thing.
I love that. The 1%, if anybody's ever read the James Clear book called Atomic Habits, the idea of doing those 1%, they actually feel like there's no gratification whatsoever. But when you look at that trajectory, it's sort of like, the powerful law of exponential growth. And so that's a really great piece of wisdom there. So I guess the other thing as well, too, is who are the target audience for your book? And what are some of those core principles or the core things that you're saying? If somebody was to finish reading that book, what would you want them to leave with?
Yeah, I think the target really is anybody in the finance sector of healthcare or anybody trying to decide if that's something they want to do. I mean, I wrote the book in in a novel perspective because I wanted it to be an easy read. I wanted people to be able to consume it. So many books on healthcare and rev cycle in particular are hard to adapt to because they're textbook in nature. And so I wrote it as a story. So it's a little bit light on really the deep details, but the objective was to either more junior individuals in the industry to get some perspective on the possibilities. So kind of the art of the possible. And then some other, maybe even senior executives, because some of the augmented analytics that I mentioned in the book and, the touch on the concepts of RPA and some other automation capabilities, just to think a little broader about what the possibilities are again within revenue cycle. But the three concepts that are the biggest takeaway, at least when I constructed the outline, was really we need new ways to measure performance. We have, I heard a guy on a podcast yesterday talking about we don't need to measure performance because that's always retrospective. We need to measure things operationally. And I agree with him. I think it's just a terminology mix up, but I think we need to measure performance in the moment and make adjustments accordingly. And that's what the three measurements are that are in the book. There's the process effectiveness ratio, which determines how well our work streams are constructed. There's the operational efficiency ratio. So how efficient those processes are. And then there's the employee performance ratio, because there's always going to be an issue or not opportunity for a knowledge worker to have to work some part of the process. And we want to make sure they're set up and the most advantageous way, where their contribution back to the hospital or the organization is maximized for the effort they're going to give.
So let's actually double click on some of these, because this is really quite fascinating about reframing a lot of what you're talking about, revenue cycle management. And so you wrote this book prior to COVID-19?
I was actually at a client's site. We were doing a large 9-month transformation. We started in January, right before COVID. And I started writing it in the middle of January. And then, of course, COVID hit. We were still running that project, but it was remote. And so I even got to adjust a little bit for remote workforce kind of concepts, measurements. But yeah, it was during the pandemic, right after it kicked off. And then I just, had an opportunity to do that. What was interesting to me, this is the first time I've written a book, and the length of the process, the book was done in probably about 6 months, but the length of the process to get published and all those things was surprising to me. But yes, during
Absolutely.
the pandemic, for sure.
So, we all know that there was the world before COVID, and then there's the world after COVID. And I think this whole thing around, when we're talking about revenue cycle performance, there was sort of traditional legacy ways that companies have been analyzing this. So what were some of the key things that you have noticed that have happened in the healthcare industry that has impacted the way people are looking at revenue cycles?
I think a lot of things that changed, where the processes had to change a little bit because we pushed all our staff home, and the current systems in place, EMRs and those type of things, are not maximized for that remote concept. And I don't know if that's ever coming back. We're 100% internal. We might have some blended where you come in for a couple of days there, but that's changed. The dynamic of the human interaction with the work involved and where they do that has changed. I had a conversation with one of my clients probably about 6 months ago around, now you have no need. They have a shortage in a workforce in their location. It's a small rural location. And I said, you can hire anybody anywhere at this point. And so I think that changed, but I need to have fundamental ways to understand that the work is still getting done, and it's still getting done well. And when it's not getting done well, at least from the human interaction standpoint, how do I provide what I talk about a lot as micro training? How do I provide the specific training to a specific individual where I know they're short, so that I can improve their performance? And we need those metrics, and some of the things that I talk about in the book, we need those measurements so that I can be hyper-focused on what each individual needs quickly, as opposed to one massive training class that may not touch on their specific deficiencies.
So Michael, this is really, really important, because you absolutely hit it right on the head, which is, if we're doing skills training, everybody has been acclimatized to this course. It's either an offsite or everybody goes to a room and everybody's learning all the concepts together and they're playing with it and talking to an instructor. That is actually now thrown out the window. We're now in a world of uber customizations, including individual skill up building, and it's kind of come to the N=1 individual learning. So what is happening in the hearts and minds of leaders today on how individuals are learning and excelling in their roles?
I mean, first and foremost, I think that's a real issue in our industry, is the education and the investment in the education. Because I would be happy if even some of my clients would do the big group training. It's usually go sit with somebody that does what you do and learn from them, and who knows if they're doing it right. So even the group training would be an improvement on some levels, but the ability to understand what people need is hard with our current systems, because I have no measurements. All I really know is that Mike Duke touched 20 today. But what I need to know is, what's the quality of that work? Even if he hit the right number from a productivity standpoint, did he do the right things in the right way? And how do I measure those without having to go in and sample 10 accounts or whatever, or piece of work, what it might be? I need a lot of information quickly to be able to do that N=1 training. And up until now, that's been problematic in the industry. So some of the
just
things,
give us some perspective, Michael, the kinds of clients that we're talking about here. Are you talking about clients that are hospital-based institution? Are these payers? Are these pharmaceutical companies? Who is typically the clients of Baker Tilly?
So we have all segments. My clients are anybody, if they provide some type of clinical care and expect to get reimbursed for it, then those are our clients. So hospitals, physician practices, surgical centers, long-term care, those type of things, behavioral health, any of those, again, that have a patient and want to get reimbursed are within my client wheelhouse.
Okay. So I want to talk a little bit about you mentioning one of the core variables that one has to really think about in this new world is around process effectiveness. Mm-hmm. Now, one of the reasons I want to sort of double click on this is because we are now moving into a space in the virtual sort of telehealth, remote work environment where we no longer have this ability to sort of be in the same room, in the same meeting, face to face, and we call IRL in real life, being able to assess how somebody is doing their work, or that they're in the office for, I don't know, 5, 6, 8 hours a day. And so this idea of being process effective now begs the question is, should the metric now change to outcomes effectiveness? And so I'd love to get your take on, this is a transition for many leaders getting comfortable of not being overhead and micromanaging and watching an employee do the work, and be much more focused on, did you get XYZ deliverables done? Not necessarily, did you follow a certain process? What's your thoughts there?
Yeah, so when I classify the process effectiveness, it's, do we maximize things where I don't even need a human being to touch it? So the oversight, yes, so needs to shift, but it should be on, am I maximizing that process and only serving up to an individual the most important work for them to look at. So in an example, a lot of the systems today, if I'm doing follow-up or whatever it might be, I have the ability to sort those work queues, the work that's assigned to me. I can make some determination as a user what I want to work on today. And one of the things from a process effectiveness that's critically, to me, is very important is leveraging technology, some business rule driven workflow that management has decided this is how we want to conduct our business to serve up what I call the next most valuable piece of work. And so the user is presented with, this is what you're doing next. I don't have a determination. I open up my app and whatever it might be, and the next piece of work that I'm assigned is there. And that's driven by, again, sophisticated business rules to present that piece of work. From there, though, I need to make sure I track what, not just how many was done, because that's predominantly what goes on today, but it's really what was done and what was the outcome. So when we talk about an effective process, you're exactly right. In the case of revenue cycle, I want maximum reimbursement for an account that has been billed. And so I look at how many was done, what was done, and then did we receive that maximum reimbursement? And those three things together determine an effective process. The operational efficiency, which is the flip side of that, is the velocity in which that process functions. And so those two together are vital importance. But you're right. I need to quit kind of hanging over employees and make sure they're working. I just need to make sure that the things that I wanted from an outcome are achieved as quickly as possible.
You also mentioned another core tenet of your book is a lot of emphasis on operational efficiency. So efficiency, we hear this all the time. We're in the new world that has been accelerated through the technological revolution that basically a lot of people's hands were forced, despite if they wanted it or not. And so you also mentioned this idea when you were analyzing process effectiveness, that automation, robotics, whatever you want to call it, computer algorithms, machine learning, all of that is part of this equation. How are you dealing with this transitionary period where people are A, potentially not very technologically savvy, or B, really concerned about their jobs or their roles? How are you transitioning during this period?
Yeah, so I'll answer those in reverse. We get a lot of that fear of, oh gosh, the consultants are coming in, I'm going to lose my job. And it's really not that. We want to make your job more meaningful. And I don't have a client yet that has so much staff that they're gonna move them out. It's more about I need 10 people in this job, I got 12. I need 10 people in this other job, and I got 8. I'm gonna move some people around to maximize the work that needs to be done. But from the kind of the importance of that efficiency and that velocity and some of the automation from a technical standpoint, I have an approach where dumb it down is not the right word, but I'd put it back in layman's terms of, look, this is what a human being would do. It's repetitive, it's constant. For example, an easy one, but when a claim has a value in box A, and that means that box B has to have these 3 values, and it doesn't, well, I can make some determination based on the data, place that in, and nobody has to touch it. That's a very simple example, but we're doing some things now where we're using RPA, we're scrubbing payer portals for information, we're bringing that back. And while that's available today, it's usually presented to a user to make a decision. Well, we're using the machine learning and a little bit of AI to make the decision on what should happen. And then we're actually performing that adjustment, rebilling, or whatever the action might be that a human would take, and making that process much, much faster. Because obviously the computer could do 1,000 of those in the time a human being could do 1 or 2. So that's part of that velocity that we're talking about. But putting that in layman's terms, it usually takes more than one conversation, no doubt.
We would also want to talk a little bit about the third core premise behind your book, which is really around employee performance ratios. Now, there's a lot of different ways to cut and splice this. And I think one of the first things that we would probably need to talk about is the so-called Great Resignation that's currently going on across the board. I think more so in the US than it is in other parts of the world, but some people are calling it the Great Reassessment. Anyway, we've given everybody ample time to sort of rethink their jobs and all sorts of things that are happening. Now, is this impacting how we're sort of viewing employee performance and or potentially this hybridization between automation and people? And what are we sort of seeing here in this milieu that we're currently living through?
Yeah, there's a couple of things. So through the course of my career, I've had people say, well, my job, I don't think I add much value. I'm just pushing this paper from this pile to this pile, or moving these accounts from this queue to this queue, or that type of thing. And so creating the value of a individual's actions helps with morale, and morale helps with retention. And so that was also part of the reason for the employee performance ratio, and to show people, look, this is how much you provide to the organization. For example, we track the EPR, or employee performance ratio, is a conjunction of the volume of work that you do, but that's not the primary driver. That's 25% of kind of the measurement. The quality of what you do, which is 50% of the measurement, and then the outcome of what you do. So it's not always about money, but the easiest example to explain that is somebody that's doing collection efforts. So I can see that you work 40 today out of 50. All right, that's pretty good. I'd like to see it 50, but your quality was 90%, where our target's 70. Okay, so maybe you had some complex claims, but you did a really good job on that quality. And here's how much money you drove. And so we have some of the augmented analytics that we use to measure these. An individual can look at their scorecard any day, any week, any month, whatever period they want, and it shows exactly how much money they drove for the organization. And so those things have been, we've found that to be very rewarding to people, that they say, gosh, for my local community, I just added $1 million to the hospital so that we can buy a new MRI machine or whatever it might be. And tying some of that performance to, the expectations, the growth, the new equipment capital, or whatever they might need from an organization standpoint, and show, hey, you really are contributing to something bigger here. Great job.
So what is the leadership doing within some of these institutions and facilities around incentivization? When we talk about complex models, which the healthcare system is intrinsically, there's a lot of moving parts and a lot of pieces. And we know ultimately the behavior is modified through incentivization models. So now that you're actually putting kind of these shiny tools in front of people and saying, wow, look at how much money you're driving in the system, how do they not come back to you and say, so what, this doesn't affect me?
Yeah, I'm personally frustrated with our lack of ability to incentivize, because sometimes HR gets involved and says, if you can't incentivize everybody in the organization, you can't incentivize anybody. So that's frustrating from a policy standpoint. But we do have the measurements now for the revenue cycle. If they use the EPR, we have goals and targets for every role. And again, it may not be cash generation, it may be denial prevention. So if I'm on the front end, for example, and my eligibility denials go down, and I contribute my work to that, I can incentivize you on that reduction. And there's a lot of other ways that we've got measurements to do that. But that is one of the things that I find frustrating for the most part, is we now have measurements to do that. If we incentivize people, they would do, in theory, you would think, a better job or more of it. But what I get a continually on pushback is, well, I'm already paying them to do their job. Why would I pay them more to do their job? And it's sometimes the limitation of HR, it's sometimes the limitation of management, more on the global thinking on how to use game theory and some other things that would push their employees to higher levels. But for sure, that is a frustration for me when I have these type of conversations with my clients.
Absolutely. And what are you sort of determining is some of the value that you would share with, the healthcare providers, the leadership of the institutions, in adopting more sophisticated analytics for their own internal audit function? So what is the ways that you actually say or explain that there's benefits to everybody involved?
Most of it comes down to everybody thinks that at this point in time, not everybody, but a lot of organizations think, hey, we've already maximized our revenue cycle operations. And so I have to go down that path of 1% each day. It leads to a remarkable improvement over the course of a year. But from an internal audit standpoint, that's where we focus on the PER, the process effectiveness, because they're trying to ensure that the work is done consistently, high quality, and there's no gaps, loss of control, those type of things. We work a lot with our risk team, which has our internal audit group, on those type engagements. But it's really, we can now measure all the failure points of a process related to rev cycle, at least, and identify when those failure points are tripped. And so it's a little more meaningful than just, do you have a policy in place? Yes. Okay, well, check that box. We can now ensure that policy that's in place is, we're seeing that in reality and results. And so it's more meaningful from that internal audit perspective.
And with the people that are involved, so the employees, the ones who are part of the workflow or the work system, what are some of the pushbacks or some of the barriers to adoption of going for these really heavily analytics, data-driven workflows? Why are people pushing back? Why are people not easily and automatically adopting these?
I think there's some fear of, I'm going to look bad if I start having this level of awareness into what I do, but or I've got harder accounts than you have, and so my job's a lot harder, and I won't be measured accordingly. But what we do is, during that part of that restructure of staffing, we like to put people in similar groups. So if I'm a commercial person, then I want to be compared to the other commercial people, because Medicare has a different rule set in which they pay and those type of things. And so putting people in like groups is important, because then I can measure, if I got 5 people doing roughly the same thing and the business rules are driving the next most valuable, therefore nobody's cherry picking work, then I can start measuring those 5 against each other. And not from a, let me get rid of some people. It's really to say, okay, this person does this. Can I take that learning of saying, maybe you're a top performer and I'm not, and say, can I take what Natalie does, take a look at that from an analytical perspective, and how do I transfer that knowledge to Mike so that he can lift his ability? So there's resistance, and I'll look bad, but I think over time they realize it's really about improving their capabilities, not in an effort to shame them or get them out of the organization.
Now, as I was mentioning earlier, is in some ways, many institutions, as well as workers, employees, individuals, we're in some ways forced into automation. We're forced into telehealth. We're forced into these automatized systems. Is there a certain level of anxiety or fatigue that is happening? And do you see some pushback as a result?
I mean, there's tremendous amount of noise, particularly around automation. I mean, you go, if you follow any of the major consumer or institutions of pushing out news, that everybody has an automation webinar coming up, for example, and we've done several ourselves and contributed to that noise. But I think there is some maybe a little, I don't know if I'd call it fatigue. I think it would just be, there's just too much going on. And if I'm a CFO, for example, I don't have a tech background. I understand RPA and concept, right? I can read the paragraph and say, okay, I understand that. But how it actually works and will it produce results for me? I think they're getting so much information, it's almost overload. And so unless I wouldn't call it fatigue, I would just say it is that overload factor of, good gosh, I don't know if any of this will work. Let me go back to what I know. I'm going to look at cost. I'm going to try to see if I can reduce employees or whatever it might be from a cost perspective, as opposed to advancing the reimbursement.
We're living in a world now, Michael, of SaaS companies, software as, as a service. Now, I'm curious about this new world that you're navigating in the healthcare space, especially around, reimbursement and ensuring that, these are optimized processes. Do you see that there's a future in continuous analytics as a service?
Absolutely. We at Baker Tilly, we designed from a revenue cycle perspective, and we're getting ready to do it with managed care, and then also what we call financial sustainability, which is across the entire organization. But from revenue cycle particularly, we launched last year what we call ARC Protect, Advanced Revenue Cycle Protect, and it is to protect their revenue cycle. And so it measures every data point within operations. It looks at outcomes, it looks at all those things, and we offer that. We host it, we ingest the data on a daily basis, and we provide that as a service. And then we wrap, my consultants around it, so that quarterly we measure last quarter to the most current quarter, and then we'll go in and tell you where we think, hey, here's some recommendations on things we're seeing in the data that you're slipping in this area, or maybe we can make some improvements in this area. So I think there's a huge opportunity for that, and we've invested heavily in that.
So we've talked a lot about analytics and precision, and we've talked a lot around the whole reimbursement model and the workflow as it relates. COVID-19 has been an experiment on its own around how all of this works and functions, and patients, if you will, cycle through the system. I was just curious about where politics fits into all of this in terms of the ups and downs of reimbursements and payers and what's going up and what's being paid now. How does Baker Tilly stay on top of this so that there's some fundamental basics on what people can hang their hat on?
Yeah, I mean, we stay pretty tight what's going on politically, because it can change. As administration changes, as legislation changes, we've got to be aware of those and how that impacts. There's some things that you can try to mitigate, and there's other things that you just have to roll with as the industry adjusts and changes from a regulatory or a payment methodology perspective. But again, what we try to focus on, there's so much operational opportunity, even when you think there isn't, that let's maximize what you have. We separate at the door. So what can I improve internally to help an organization be successful? And then we try to take a look at the external outside of the door. What can we mitigate, or do we need to adjust services so that if CMS changes a reimbursement policy, do we need to create an outpatient center and help our clients change that service line from an inpatient to an outpatient? I mean, again, another easy example, but that's how we help our clients, as we look at through the lens of internal and external. Can kind of keep those separate, because no matter what the reimbursement mechanism is, I want to maximize it internally. And then whatever the changes are externally, how do I adjust the business to be able to account for those?
So we're living now in a world, this was certainly accelerated by COVID, in a very patient-centric world. So getting away from just workflow and automations and numbers, how are your systems starting to integrate the voice of the patient in ensuring that all systems and workflow is following the needs of the healthcare consumer?
Yeah, there's two things that we're focused on. Helping our clients do a better job up front. If I can tell a patient you're gonna owe us $200, that's what they expect. They can do that anywhere else. If I go buy anything else, I know what it's going to cost me. So estimating that cost up front, I think is critical, and that's one of the things that we're helping our clients with. But there's also on the back end, instead of getting 15 bills, and if your insurance company rejects it for some reason because we did something, and then you get the client, you get the bill and said this hasn't been paid yet. As a patient, you're going to be frustrated because you really don't know that business. You don't know what all the codes and rejection reasons are. All you know is it says there's $500 outstanding. And so if we clean up our revenue cycle internally so that we don't have as many errors, then there's less frustration for the patient on the back end from a bill standpoint. But also if we tell them accurately upfront what they owe, then there's more patient satisfaction because I know, all right, I'm coming in for this service. I know I've got to pay $200. I know that, and then I don't get a bill for $600 on the back end and wonder what the heck happened. So I think those two things, that's where we're helping our clients. But those are two things that I think drive a lot of patient satisfaction improvements, just knowing what they need to know.
And data analytics data is the new gold. Everybody is consuming it. Everybody wants it. And so in some ways, companies are actually selling their data as one of their models. So I think in this new world, as you're collecting all of this information, is who's getting paid what is the cycle, how long is it taking, what drugs are getting paid versus not. I'm just curious on the back end, who are the new clients? Can this become a subscription basis? And will the business model change for Baker Tilly over time?
Absolutely. There's some things, I don't know if the clients change, what they're asking for is changing. You point data is gold and it's coming at us from a lot of sources. But one of the things that we've done, we partnered with IBM and their Watson claims data. And we have a lot of our clients saying, hey, with the price transparency and other things where I've got to have more information to present to my patients. How can I understand, for example, what's my market basket? What do my competitors charge for this? And how can I get a handle on that? So that's one. What are my rates? So when I'm talking to insurance companies on reimbursement, well, if I'm getting paid $200 for a hip replacement and everybody else is getting paid $10,000 in my market, how can I make that better so that my reimbursement is higher? So that type of millions of claim data is becoming more and more prevalent for certain. But there's other data as well that's comparative from a cost side. So if I'm in a specific market and I have like competitors that are similar to me, what is their cost structure and how can I understand for what service lines, where can I make improvements, where there might be opportunities. So some of that data that's aggregate in the industry as well is also becoming vitally important.
We're living in a world of blockchain, cryptocurrencies, obviously a sidebar, but there's all kinds of things going on in the digital space as it relates to information. Also, this concept of DAOs or decentralized autonomous organizations, and the idea of smart contracts and Oracle chain links, these sorts of things. In the world where we can eventually realize that based on algorithm, if certain parameters are met and certain outcomes are met, that people are going to get their reimbursement without having to go through third-party payers. Is this of concern to Baker Tilly, or is this an opportunity that you will be leveraging in the future?
I think the best thing about being a consultant is any disruptive changes is an opportunity because there's always going to be some level of clients that need help with that disruption. And one of the biggest things that I think we're going to see, and we're actually playing in that space now, is the interoperability. And that's some of that blockchain capability that is exciting because right now, if I go to a hospital in Portland, Oregon, and I'm in North Carolina originally, none of that information really comes back, right? I have to tell somebody, hey, I went and I got this. We could be living in an environment with blockchain, particularly because of the security protocols, that information could just be shared natively. Now, there's a lot of regulatory, and individual hurdles for that, but it's exciting to know that that's a possibility. Not just from a clinical standpoint, but in my world with revenue cycle, it becomes really important because what I don't always know is if you've got a $200 deductible and you went somewhere else and paid that $200, it's not always available to me on the payer sites that's been processed. And so I might ask you for your $200 deductible and you tell me I've already paid my $200 deductible, but when I go to the portal, it looks like you haven't paid the deductible, so I have no way to know. And so having some of that sharing of information in a secure fashion, I think will streamline even more the revenue cycle work and the general financial work that goes on in healthcare operations.
Absolutely amazing and very exciting. We have a lot of people who listen and watch our show who are in the pharmaceutical and life sciences industry. What can pharma do in this area? Can they partner with Baker Tilly? Is there information or data that can be shared? What would a pharma company do in collaboration with Baker Tilly?
We do a lot with pharma. I'm not in that space, so I can't give you a lot of the details. Or I'd be, as we say, I'd be over my skis pretty quick. But we do have individuals that live in that world and play in it all day long. And there's several things around. I know there's some ops improvements, but there's also getting drugs to market and some other things that they do a lot faster that we help with. But again, I would. I'd be over myself pretty quick if I went much further.
Well, very exciting stuff that's being worked on here. Obviously, lots to think about in this world of automation and data and all sorts of things. And I'm sure that Baker Tilly is going to be leading the way on this. So we're going to be closing the show now. So this was a fantastic conversation. I hope everybody enjoyed it. If anybody is interested in contacting Michael, we will be leaving his details in the show notes below. So please be on the lookout for that. Also, please check out impetusdigital.com. These are the kinds of conversations that we have a lot with physicians, allied healthcare providers, payers, patients. We work with people asynchronously and synchronously through a variety of touch points over time to move the agenda forward, to come up with new agenda items, strategies, policies, procedures. This is exactly how we get people to work asynchronously together. And Impetus actually helps to collate and develop that with our white glove services as well. So we want to thank everybody for their time. Michael, this was an outstanding conversation, and thank you, everybody, and enjoy the rest of your day.